And no question is silly. This is complicated stuff. It's even complicated for the transplant doctors, and some of them are smart. Not all of them. Question here, Miriam? Yeah. Stand up. I'm going to repeat. Yeah. Yeah.
A2 donors that you're suggesting for the B recipient.
Yeah.
In order to do that, will they have to receive more immunosuppressants?
Right. So the good question is, if we're using a blood group A2 donor for B recipients, the answer is no. This practice has already been done. The London program has been doing this for years, in fact, and you do not need, the reason we've chosen an antibody cutoff of 1 in 8 is because that seems to be safe to do with the antibody titers are low and the antigen on the A blood group is low, and you can do that without any additional immunosuppression. There's no desensitization. Excellent question. Thank you.
Since we have a Credit Valley staff standing up with a question, and I think you answered this question for me, Dr. Zaltzman, before, but Credit Valley shifting to, you said Hamilton, will not prevent them from sending their living donor recipients to us, correct?
Correct. Yeah, so what I've been talking about mainly is deceased donation. And we're not mandating that anybody, it's hard to police this in the first place, but if patients have living donors and they like how a living donor program operates, they can certainly send their living donors anywhere in the province for that matter. There are some programs in the province that don't do every kind of living donor. So they'll send someone else, and there's some programs that don't do any living donors, some very small programs. So yes, this has nothing to do with living donation referral. Question here, and I think there's going to be one out. Yeah, so
Doctor, as a family member of a dialysis patient, I'd like to thank you so much for your excellent explanation to a non-medical person of how this whole thing has worked. B, thank you. I'd like to congratulate you if you're the person who managed to herd all these cats together to make this work. And I have nothing but extreme excitement about the production you've put together, and thank you so much for a well-organized presentation.
Well, thank you for your comments. The truth of the matter is that many of us, I'm not the only one, many of us have recognized the flaws in the system. We've been able to make this happen through really a committee of people who represent actually all the transplant programs in the province, and some of them have had to sacrifice. Everyone's had to compromise a bit, and Trillium has been instrumental. But in fact, is the government. The reason we're able to do this is that the government is asking us to do this, in fact, and it's the right way to go. So now that we couldn't do it without some teeth. And although we've tried in the past, now that we've got some legislative ability to make this change. So I have been very passionate about this for a long time, but now we've had some help. But thank you. I think you have a question here. Yes.
I'm a nurse from Credit Valley.
Yeah.
Home hemodialysis. Would our patients that are currently with St. Mike's, they would continue to be with St. Mike's, and for new transplanted patients, we would further them on to Hamilton?
Yeah. So thank you for that. So the current waiting list, regardless of where people have come from, is not going to. We're not going to shift that. So it's only moving forward prospectively that it's only for new referrals. So there's already been lots of discussion with Credit Valley and Oakville with the Hamilton program, and similarly with Kitchener-Waterloo. So the answer is yes. Everyone's aware of it, but it's only prospectively. We're not going to disrupt anybody who's already known to the program. That would just be silly and lots of work for no reason. But thank you. Question here. Yeah.
Well, I'm a dialysis patient with AB group of blood.
Yeah.
My sister wanted to give me a 1500 Libya in this country, and she has got a blood of A type. Is there any possibility that it can match?
So I'll just repeat the question. So for deceased donor, we typically allocate by blood type, and I with the exception that I alluded to for A2 to B. For living donation, anything goes, by the way. We now have the ability, if you have a living donor, and this is sort of separate from the main discussion, if you have a living donor, don't worry about the blood type. So in simple terms, if you're AB, by the way, you can get from any blood type. AB is the universal acceptor without doing anything else. And if your blood group is O, you can give to anybody, the universal donor, as it were. But even if you have a donor whose blood type is different or you're not sure, this is a separate conversation, and you can ask Gallo about it afterwards, and he can talk to you. We have the ability now, through our national paired exchange program and through desensitization, to do almost any donor combination. Even if we can't do it directly, we have mechanisms for that to occur. So AB, just for you point of view, you're very lucky because anybody in the world could give to you. Anybody in the world, as long as you don't have antibody. So it's a big pool to choose from. In the back, in the green, and then in the, yeah.
Just a question. For those patients that are already in the program, that's waiting for a long time, will you be recalculating their time to get that point?
Yeah. So the question is right now, Teresa, there's no point system in place. So it's all about waiting time. So because it's driven by waiting time, it doesn't really shift, okay? It turns out that where people's places are probably not going to shift very much, because if they've been waiting a long time, that's going to be the biggest driver of the system. Where it may shift is that someone who comes on the list who hasn't been waiting very long but who's highly sensitized, but today they would still get priority. So we don't expect there to be a major shift, because if I get on the list today and I have a PRA of 80%, I get high priority and that's already happening. We're just trying to make this a bit fair by a continuous spectrum. So it'll be calculated for everybody, but right now there is no point system. It's just kind of wait time, and that's it, with priorities for highly sensitized.
I was going to ask you, the antibodies, how will we figure out what our percentages on the sensitivity level?
If you're on the list?
Yeah.
So you can ask, do the dialysis units know this, Miriam? No. If you want to ask and you're not sure, you can call the transplant office to find out your exact PRA. And it doesn't change very much. It can fluctuate a little bit, but you can ask to find out, or if you see the physician, if you're coming for a reevaluation, they often will tell you. Okay? But it's a good question. Most people don't know what there are. In fact, even people who are not on dialysis, some people are going to be sensitized for the reasons I already told you. So if the dialysis unit doesn't know, you can certainly call the transplant office to find out.
How does it fluctuate?
You know, the levels of antibody will wax and wane over time. If you get a new blood transfusion, it can go up. So even amongst the antibody levels, it can go down a little bit. But it generally doesn't go down that much. Unfortunately, it can only go up. Good question. Yeah.
Dr. Zaltzman, may I ask what's the age of the deceased donor kidney that can still be used for transplant?
Okay, so the question is there an upper age limit? The truth of the matter is there's no hard cap on a deceased donor for age. We look at age and we look at other medical issues. So you could have a 40-year-old donor who's got heart disease and diabetes and peripheral vascular disease and smoker, and that donor may not be good as a 65-year-old who's otherwise perfectly healthy, who happened to fall off her motorcycle and smashed her head. Okay? But in practical terms, it's rare that we'll use a deceased donor over the age of 75. I would say 80 is about the maximum that has been used. That's in practical terms. It's possible, but it gets very, very slim choices after that.
Some nurses might be thinking of this question, so I'll ask this for them. With the new system, is the zero BDR mismatch still applicable? And if so, can you explain that a little bit so people would understand why some people get kidneys sooner than others?
So you're asking, are we going to give any points for better matching? And the answer is no. And the reason is that the antibodies that we've identified are so numerous that it's going to be very, very hard to actually find matches based on HLA compatibility. The reason that some people in today's system may get a kidney much faster, even though they haven't been waiting line, is that maybe their PRA is 81%, so they're highly sensitized, but they've only been on the wait list a short time. The current system gives them very high priority. So they could be only on dialysis for a few months, but there's a kidney that matches them. Remember, if you're 80%, then 1 out of every 4 kidneys will be suitable for you. 20% of kidneys will be okay, 80% will not be okay. Sorry, 1 out of every 5 kidneys. So if you happen to get 1 kidney, you could be getting a kidney through high priority, even though you have no waiting time points. That's why the new system that looks at both sensitization, PRA, and waiting time is much better. But occasionally you'll say, why did this patient get a kidney so fast? And because they may have been sensitized, and the old system, the one that we're using today, just gives them high priority. And that's probably not right. That's why we're changing it. Sorry, there was, yes, sir.
There's a
Yeah.
If you're already in the list for St. Mike's,
Yeah.
can you elect to move to the Hamilton area?
The answer is you can, but not easily. You can, but not easily. It hasn't been a practice that's easily done, and part of the reason is just there are some patients who are on lists who live in different cities. You probably can't do it yourself. You probably need to have your referring doctor make those arrangements for you. It's doable. The truth of the matter is the waiting time right now between Hamilton and Toronto is not that big. The real difference is the London waiting time. That's really where the major discrepancy seems to be. Yes, Miriam. Sorry.
I'm just going to say this microphone.
Yeah. Sir.
There's a microphone there.
Yeah. I'll repeat the questions if people can't hear them. Yeah.
Apparently, organ donation in Spain is very high.
Yeah.
There was talk about that recently. Has there been any discussions to emulate that system in
Right.
Ontario?
So Canada as a country doesn't do as well as other countries. So Spain has a lot of things in place that are working for it. Spain has what's called presumed consent, which means everybody's a donor unless they opt out. Spain also has a system where they, if there's an accident victim, let's say from a car accident on the street, who has just died immediately, they will actually resuscitate that person with CPR and intubate them, artificially ventilate them, and bring them to the hospital, and then put them on a machine to perfuse their organs. And they can do that because they have preferred consent, and then they will call the family about organ donation. So that's something that doesn't exist in Canada and probably will never exist. In addition, they have a system of ICUs where the ICU doctors there are, I have to say, highly motivated for organ donation because they get paid based on performance. It's like selling shoes. In addition, in Spain, and they've put a lot of, in fairness, they put a lot of resources. In addition, in Spain, again, culturally, it's a fairly uniform country in many ways, and that's been able to get the message out for the population. So Spain is a very, very good model. Canada is doing better, but I don't think we'll ever reach Spain's capacity. Back there was a question. Yes. Do the antibodies ever go away? No. The antibodies, unfortunately, never go away. They're always there. Even if they're very low levels, they can come back. That's the whole idea. Like when you get a vaccine, the antibody levels may be very, very low if you get that vaccine, but when you get exposed to the virus, they come in. So your antibody levels never go away. They could be low, but if you get exposed to the new kidney, they can rev up and destroy the kidney quickly. That's why we make a big deal about understanding them and knowing what they are for every individual patient on the list. Yes, ma'am.
Is a donor kidney ever rejected?
Yes. So the question is a donor kidney ever rejected? It is. There's the way it works in Ontario is that there's a rule now in place. Every ICU in the province that is either recognized a potential donor because of what's called brain death or in someone whom they're going to withdraw life support, they have to call Trillium. There's a trigger that they have to do this by law. Trillium then has a set of standards depending on the quality of the donor to say we want to proceed with approaching the family for organ donation, or if it looks like the donor has too many medical problems, they'll say no. Sometimes they will approach the family and they may not get consent, which is a problem in this city. Sometimes they will get consent, and when the organs are examined more closely, either by x-ray or by function, they realize they're not so good. And I think the point you're asking me, sometimes they will begin to procure the organs. The donor will go to the operating theater, and when the organs come out, they just look bad and they're turned down. So yes, a number of times, more times than, especially as we start getting with older donors and sicker donors, we are unfortunately having many more donors in whom the organs can't be used. And an organ donor can donate, heart, lung, liver, pancreas, kidney, small intestine, and tissues like corneas, heart valves, bone grafts. So many donors may donate some organs but not others. There's criteria for every donor. Sometimes the family has consented to organ donation, but all the organs are not good, so they'll just donate tissue, which is fine. So it's quite variable. It happens all the time. Thank you for the question. Yes?
If someone agrees to be on the extended criteria list, are they solely on that list?
No, they're on a parallel list. So the question is, if you're on the what we call the extended criteria list or older donor list, for lack of a better term, you are on a parallel list as well. So you can still potentially get a kidney from a so-called younger donor, but statistically, you're much more likely to get it quicker from an older donor, just by the way the donors are relative to the recipients on the list. Yeah.
Doctor, may I ask, if a patient, a dialysis patient, has already undergone bypass surgery, and then he had a cardiac arrest, and then he had an emergency intestinal surgery, is he still going to have a transplant, or what's the decision about that condition?
So today, and in the past, and moving forward, when someone is on the waiting list for a kidney, regardless of whatever system we've talked about or we're going to be implementing, the dialysis centers are always in contact with Miriam, who was here before. Where are you, Miriam? Letting them know about the recipients, and we're always in communication. So you could be on the waiting list for 5 or 6 or 7 or 10 years, and you're at the top and you're all ready to go, and then unfortunately something happens to you medically. You have the situation that was described, bypass surgery and a whole bunch of things. At that point, you are put on hold. That means that you are not going to get a kidney offered to you while this underlying medical condition exists. And that could go on for months and sometimes years. If you have a cancer, we want to make sure that you are clear of that cancer before we transplant you. And any time in the province of Ontario, about a third of the wait list, so 1,000 people on the wait list, about 300 of them are on hold at any one time. Now, you do not lose your spot on the wait list. In other words, you still get time. You still get your points for waiting time and your sensitization. That doesn't change. It's just that you will not be offered a kidney while you're on hold. And the minute you get better, and we know about it, we take you off hold. In the meantime, you've gravitated up higher on the wait list. So that isn't changing too much. But what is changing is that if we don't have your blood to test your PRA, you will be put on hold. Okay? So that's why I keep emphasizing that point. So the hold active list is a very fluid thing. It's always, there's always people being put on hold, coming off hold, that. And you will not be allocated a kidney while you have a serious medical problem where we think it's not safe for you to get a transplant. Remember, you're getting a transplant, you're going for big surgery, you're being exposed to anti-rejection drugs. It's not safe, but when you get better and you've been evaluated and maybe you need testing and maybe some other things, you get activated, but you haven't lost any time on the wait list. You still accumulate waiting time. Sir?
Thank you for your time. I was going to ask if a recipient of a kidney, their PRA rejects a kidney, would that kidney be used by another recipient, or what's the timeline of being able to reuse that kidney again?
So if a kidney is rejected in the recipient, no, unfortunately the kidney can't be used. It's too damaged. Yeah. Sir.
How long after a kidney from a deceased person has been taken out, how long can it preserve?
So the question, it's a good question, is if the kidney comes out of a deceased donor, how long can it be preserved? Well, ideally, we like to get the kidney in the sooner the better, because when it's not being preserved, it's usually kept cold with fluid. And the longer it's out there, the worse, not the worse the outcomes, but it's more likely not to work right away. It's called delayed graft function. We'd like to get them in within 24 hours, and we usually do much better than that. We're averaging about 12 hours now, but 24 hours is where we get a little bit worrisome. What the other change that's been made in Ontario, in fact, not just in Ontario, but most places, is that now most of the deceased donor kidneys are placed on what's called a kidney pump. A pump is about the size of a VCR, and the kidney is kept cold, and the perfusate solution is going through the kidney. Instead of it just being static in a cold cooler, it's actually on this little pump. And what we know with the pump is that it actually allows the kidneys to work faster and work better. So we've moved in the last 6 or 7 years to pumping almost every kidney that can be pumped at the time. But 24 hours is when we start to get a little bit antsy. Yeah.
In regards to that, then how come if you have a kidney that's in Vancouver and we need to send it to the Maritimes?
Exactly. So these are going to be situations, in fact, where it may not be ideal. The ischemic time may be longer, and programs are going to have to make a decision. What we're hoping to do in Ontario, and not every province has the resources, is that if there's a kidney in Vancouver for a Maritime or a Toronto recipient, we're not going to put them on commercial aircraft, because you guys know what it's like on Air Canada, right? What we're going to try and do, and it may not happen all the time, but the plan is the following. The surgeons that recover the kidney in Vancouver will put it on a pump, a Vancouver pump. Orange, which is the air ambulance, is going to fly a plane out with a pump on it, drop the pump off in Vancouver, so we switch pumps, and hopefully bring the kidney back on a pump to Toronto or London or Halifax. Well, I can't speak for Halifax. So we're hopefully going to try and minimize the ischemic time, even though it's a long flight. We don't want to be dependent on commercial aircraft and losing kidneys, which they've done, or flights delayed because the pilots have been waiting too long and they have to change the shift. So we're going to hope to use. We have a contract in Ontario with Air Ambulance with Orange. And although they haven't always been popular in the news recently, they have done a fairly good job with this part, so we hope it works for them. But it's a great question, and that's our plan. It may not always happen, though. What's that? Time will tell, exactly, yeah. Other questions? Yes?
Sorry. Hi, Doctor. I was called to the hospital for possible transplant about 3 weeks ago, and then I just found out, unfortunately, it wasn't a good kidney. Now, will it affect my standing, if you will, of my waiting time?
Okay, so that's a good question. If you get called in to St. Michael's or any of the transplant programs for a potential kidney, it's conceivable that you may not get that kidney. And there's a number of reasons why you may not get the kidney. Thank you. One is, as the example that you've provided, is that the kidney itself, we didn't know until it came out that it wasn't good. All right, that's number two. That's number one. Number two might be that maybe you're a backup for somebody else. And sometimes we'll call in more than one recipient because maybe the first recipient we're worried about, so we want to bring a second person so we don't waste a lot of time. And that's the most common situation. So that's the second reason. The third reason may be that occasionally, and it was one of my earlier slides, but there are some organ donors that are called donation after cardiac death, where we're actually awaiting death of the donor to occur. So these are people who have brain injury, but they're not so-called brain dead. But a decision has been made to withdraw life support, and then a second decision has been made for them to become organ donors. It's fairly complicated, but in that situation, after they're removed from the breathing machine, we wait a certain amount of time for them to pass away for the purposes of organ donation. And we generally wait about 2 hours for kidneys. Occasionally, more than occasionally, about 20% of the time that doesn't happen. So we're all set to go. We bring in a recipient and we're waiting for the kidney to come out, but the donor doesn't pass away. We call it off. The surgeons go home, the recipients go home, and everybody's disappointed. So there are going to be many times where many of you are going to be called in and it may not work out. Sometimes it's because you have a medical issue that we didn't know about. So in all the situations that I've talked about, you do not lose your spot on the wait list. You just got called in, but it wasn't your day because the kidney or the donor didn't work out. And your priority doesn't change. If you come in and we find out that you've got a medical problem that we didn't know about and you need to be placed on hold, well, that's a different story. Then we put you on hold. Again, you don't lose your waiting time, but you won't be offered a kidney until, as I told you earlier, that on hold situation is resolved. Okay, but for those other reasons, for what you've said, there's no reason that your priority or your wait time changes. Sir.
Well, I know the risk factor of the kidney that I'm going to receive, wherever it's from.
So the question is, will you know about the kidney itself? We try not to give you too much information about the donor, only to try and keep the family private, the donor family's privacy shielded, intact. Sometimes, though, we will tell you some things about the donor that we need you to know to make an informed decision. So this is, again, an important point, and I'm glad you raised it. Sometimes we have donors that the transplant team thinks is good, but the donor may have some additional risk factors. And we use the term exceptional distribution. And Health Canada means, from a Health Canada point of view, we need to inform you about this. Now, we don't always understand the risk factors, but let me give you one example because it's the easiest one. The risk factor for HIV. Now, we test every donor for HIV and for hepatitis B and for hepatitis C and West Nile virus and syphilis and a whole bunch of things. And we do not transplant donors that have these infections. Okay? But occasionally there may be a window where someone may have been infected and the test doesn't show up. That has not yet happened in Ontario. But there are some donors that are higher risk. Let's say, I'll give you an example, the highest risk donor that we may not use. A donor who's young, who died of an IV drug overdose, okay? That donor is at risk of getting infections, of having an infection like hepatitis B and hepatitis C and the HIV virus. That would be a very high-risk donor. I may decide I don't want to use that donor, even though we've tested the donor before we use it. We test the donor long before the organs come out. And we know that the donor is negative for HIV, hepatitis B, hepatitis C, even though that donor is a very high risk for those things. But yet, I'm still not comfortable because maybe there's a window where maybe he got HIV today and the blood test hasn't shown up yet. It's never happened in Canada, but it's a high risk. And Health Canada would call that an exceptional distribution donor. I'm giving you the most extreme example. Most of them are not that obvious, in fact. Someone with a tattoo, by the way, could be an exceptional distribution. Half the world has a tattoo. I'm just giving you two extremes. But maybe I don't want to use that donor, but my colleague says, you know what, I like the kidney, I'm going to give it to you. In that case, you will be informed of that risk up front, and you can decide yes or no, whether you want to do it. And they can actually give you some statistics. So usually most people wouldn't accept that kind of donor. I'm giving you the most extreme example, but it's often much more subtler than that. So if there's information that you need or that we want you to know, in fact, you have to know, you'll be informed of that. But you're not going to know that this donor came from a 42-year-old teacher who worked in wherever. That's too much. Having said that, after you get your kidney, we strongly encourage you to write a letter of thanks to the donor family. It's done anonymously. It's given to us. We give it to Trillium. Trillium passes on to the donor family. It's a it's a way of expressing your gratitude. You could thank them without going into personal details of who you are. And it's a very, very important thing for the donor families, and we strongly encourage that. And they may write back to you as well, again, anonymously. But that's kind of the extent of it. I hope I've answered your question. Kevin in the back, and then, yeah.
Yeah, this might.
So you've mentioned a few examples of change that's happened over the years. Some of it's been political, for instance, mandated by Ontario, and some of it's been technological. For instance, the use of a perfusion machine with transporting kidneys has now opened up a national registry. Can you give some other examples, like, for instance, virtual cross-matching or even within ABO compatibility?
Sure. So one of the best examples of how we're able to use the technology better is that in the old days, we would consider, I'm going to go back to that PRA, panel reactive antibody, we would consider someone with a PRA of 80% as a high risk for a transplant because they had a lot of antibodies, but we couldn't identify the antibodies. We didn't know what they were. So those people were given lots and lots of anti-rejection drugs because we were worried that they were going to reject. What we now know is that if their PRA is 80%, if they don't have they have lots of antibodies in their blood, lots of antibodies, but if they don't have an antibody against that donor, we don't have to be as worried about them rejecting that kidney or giving them higher dose of immunosuppression. So that's how the virtual cross-match and the antibody, which has really only been about the last 5 or 6 years, has changed the way we practice. That's a good example. We also have the ability to transplant against blood group incompatible living donors. We have a national paired exchange. So if I'm blood group A and I have a donor whose blood group is B and she wants to give me a kidney, most often wives give to husbands. They're much nicer than husbands giving to wives. So many more women give to their spouses than the other way around. So my wife is nice, wants to give me a kidney, but she's the wrong blood type. Well, we could be entered into a national system and find a match where a blood group B donor, she can give to a blood group B recipient and an A donor can give to me. So that's another technology that's existed. And sometimes even in St. Michael's, if my wife is blood group B and I'm A, and for whatever reason we don't want to go into the national system, I could be treated with additional therapy to allow me to get this incompatible blood type. So a lot has changed over the last 5 or 6 years. That's really, really, really helped us improve access and outcomes. Yeah.
You said that blood should be tested at least every 3 months for the PRA.
Yeah.
Why isn't that done automatically in dialysis?
It should be done automatically. Sometimes it gets missed.
Okay.
Maybe Miriam can answer that question. I don't know. Miriam?
As far as I know, it's done together with your monthly blood work. But for those patients who are on home dialysis, I think there's certain time that your center will ask you to draw blood from home and then bring it to the hospital for them to send it to the lab.
Yeah. Now, just along those lines, so most dialysis patients are getting blood work every 6 weeks. Is that fair? Is it 6 weeks? Yeah. We may begin to get the HLA with the monthly blood work for 2 important reasons. Number 1, it becomes part of the routine, so you don't have to think about it extra. And number 2, if we've got relatively fresh blood, let's say 6 weeks or younger or less, then right now, if we bring someone for a transplant, let's say who's highly sensitized, okay, we're giving them that kidney based on a virtual cross-match. But we still have to do a real-time cross-match with today's blood against the donor, just to be sure that our computer models predicted this kidney would be okay. So we do what's called a stat cross-match. So the recipient is highly sensitized. They get called in for a kidney. They're waiting for their transplant. And today what we do, and what we'll be doing in the future, is we take their blood and then we test it against the donor just to be sure that we can go ahead. If we have fresh blood in other words, 6 weeks old or less, then we can actually begin to do that test even before the recipient comes in. It'll save time. So in Ottawa and London, where the waiting lists are relatively small, they've been doing it every month, believe it or not. We haven't mandated that, but I think in the future we may add the HLA blood work. It'll add cost to us, but that's a separate issue. But we may just do it in conjunction with the monthly dialysis blood work or 6-weekly dialysis blood work. It may save some time. We're not there yet, but we may get there in the next little while. Sir.
Well, if I recall from your chart, I saw that AB blood group, it is the lowest that is...
Lowest numbers.
Yeah, lowest numbers. But if it is like this. If it is an universal recipient, why the green line, green bar is not going up?
So just to show you, the blue are the number of AB donors, or the percentage of AB donors. The red are the recipients in the province of Ontario, and the green is St. Michael's list. Okay, so there's a little bit of discrepancy. AB is the lowest blood group, so they're the lowest donors, of course, okay? But there's not much difference between here. Having said that, AB is one of the best blood groups to be from a deceased donor point of view. And the reason is that an AB donor can only give to an AB recipient. So at St. Michael's, we've got the largest AB list in the province, probably in the country actually, I would say. We have the largest waiting list in the country. Sometimes we will get AB donor kidneys from other provinces. I'm not talking about the national sharing now, I'm talking about what happens today. And that's because the other provinces are so small, they may not have anybody AB on the recipient. So for example, 2 weeks ago, there was a donor from Manitoba whose blood group was AB. In Manitoba, there was nobody on the AB recipient list. So we got that kidney. So an AB is pretty good to be in. But overall, there's not much difference between the donors and recipients. Those are fairly small differences.
This is what you are telling about the disease donor, right?
Yes.
Okay.
This is only for deceased. An AB recipient from a living donor can get from anybody, from O, from B, or from A.
Jeff, there's a question. As you mentioned earlier, some of the A kidney will be given to B. So is there a monitoring system to make sure that the A group will not be disadvantaged later on?
So the A group will never be disadvantaged. Remember, the A2s are only 10% of this group. So at most, we're going to go from 35% donors to about 32% donors. It still far exceeds the recipients. So even by shifting 10% of the A group, the A2 donors, that's all there are, the impact is going to be minimal on the A's. The A's are at a major advantage. They will always be at a major advantage.
I have a question.
Yeah.
So doctor, I'm a dialysis patient and I'm type O. And so my question is, for a transplant doctor, what kind of PRA you'd like to see in a patient before you decide to give them a kidney? Like, what's the ideal PRA level for type O?
So just to be clear, the blood type and the PRA have nothing to do with each other, okay? It's not what we would like to see. It is what it is, right? The higher your PRA, the harder it is to find a match. That's why we're giving some points for PRA. Ideally, you'd like to have no PRA, but that's not always possible. So it's not, you're not listed whether you have a PRA of 0 or 50 or 100%. That has nothing to do with it. It's just a question of trying to find a kidney that matches you. So the PRA has nothing to do with the blood types, nor does it make any decision about whether you get listed or not. It just becomes part of your ability to receive a kidney. The higher your PRA, the less kidneys are available for you to receive. That's all it comes down to. I think you had a question first.
She basically asked the question. My mother has O positive, so she has to receive O positive.
Right. So again, for the deceased donor, we tend to give A's to A's, B's to B's, AB's to AB's, and O's to O's, with the exception that the A2s will be given to some of these B's. From a positive and negative point of view, for transplant, that does not matter. So we don't care about A positive, B positive, O positive. Positive and negative doesn't matter. But O kidneys are allocated to O recipients, and it's fairly evenly balanced here. The only unfair group here, or the only disadvantaged group, are the blood group B recipients. I think you had one first, yeah. Hang on one second. I'll come back to that in a second, yeah.
So if you're a B recipient,
Yeah.
and you can, you're one of the 10% that can get the A2, are you explaining that to the patients? Are they being told when they get called? Or
Yeah. So we are devising a letter. Sorry, just to be clear, only 10% of the A donors are A2. The B recipients could be more than 10%. It depends on your antibody. So we are formatting a letter now as we move forward just to try and explain that to them. It doesn't have any impact on their graft survival or any additional anti-rejection. But we will explain it to them. And we're just trying to devise a letter now yeah.
Will the dialysis centers receive a letter as well that the patient does match for receiving an A2, just so that we're aware? Out of curiosity.
We haven't really thought of that, but we certainly can. Yeah. Sorry, you had a question in the back?
Jeff, I just want to add, for those patients who are blood group B, we've started we asked them to go to St. Mike's so that we will be testing their anti-A titer and anti-B titer. And then majority of them have done it already, and I just have to show it to Dr. Zaltzman, who are among those patients in the B group who will qualify to get an A2, and maybe we can discuss that later if we can notify our center that these are your patients who might qualify to get an A2.
So any blood group B recipient who has a titer of 1 in 8, 1 in 4, 1 in 2, or 1 in 1 would qualify. Sir.
You've moved the picture. Is it the B group, the second line there? And there's a discrepancy between the donors and the recipients. Why is that?
Why is that? Does anybody know the answer? You know the answer? Speak.
Well, it's possible. The immigration process?
Right. So I told you, I'm glad you asked the question. I was egging someone on to ask me the question. So I am going to be politically incorrect here. Toronto, we are blessed with a very culturally and ethnically diverse city. But it turns out that blood group B recipients tend to be very, very highly represented in the dialysis centers. And I'm going to speak about Caucasians and everybody else, because I'm not going to single out any one group. Caucasians, which is a euphemism for white people, are only 8% blood group B. Okay? Some people from other cultures are up to 40 to 45% blood group B. So we have a lot of people on dialysis who are blood group B because of where they've come from, and especially in the GTA. But unfortunately, they are not donors. Not them, but their ethnic culture groups are not donors. It's not because people are bad or whatever, but people are coming over. They don't always trust their government. They don't trust the healthcare system. They're not thinking about organ donation because often people are thinking about just trying to survive in a new country. So we have a major discrepancy. And St. Michael's is more than the rest of the province because of our catchment area. So Scarborough General, is anybody here from Scarborough General Hospital? Raise your hands. Scarborough General Hospital, which refers all their patients to St. Michael's, is 48% blood group B recipients. Okay? More than double the provincial average. That's why St. Michael's is higher than the province, mainly because of Scarborough. So we love Scarborough. They're our best referring hospital. But the Scarborough B recipients, so this unfortunately is a fact of life of living in the GTA. We've got, unfortunately, a group of donors that are not matched to the recipients just based on blood type alone. Trillium has this data, we know about it, and we have to try and, this is a long-standing process. So Trillium is going to every high school in the city of Toronto to talk about organ donation so that the younger members of the family, the second generation, or maybe their first generation Canadians who are coming from diverse cultural and ethnic backgrounds, will buy into this system, but it's going to take time. So that is the disadvantage here. And that's a big reason why the province, and particularly St. Michael's blood group B recipients, there's a bit of a disconnect between those who donate versus those who need, just based on where you come from. And that's the PC incorrect statement. Back in the orange. Yes, sir.
Getting back to the waiting list for a moment, Dr. Zaltzman.
Yeah.
It's my understanding from what you've told us, you said in 2 weeks, so I assume you're talking about February 14th.
12th, actually.
February 12th, so we're missing Valentine's Day. Anyway, on that day, everyone on the waiting list will have a points.
Yeah.
Or points, I should say. And is that information going to be easily accessible to a potential recipient?
Easily accessible?
Well, is there going to be a website where...
Yeah.
I mean, is confidentiality issues and all that, so...
So let me ask, there will be a website going through some of this. Trillium is going to have a website for the province explaining some of this. Clearly, patient identification material will not be on there for all the other reasons. You know, for the most part, you could do the calculation yourself, in fact. You could actually know how many days you've been on dialysis and figure out this easily enough. And if you know your PRA, you can do the math. And this is going to change every month. The truth of the matter is that you could have very, very high points because of waiting time and sensitization. It still doesn't mean you're going to get the next kidney, because if the kidney doesn't match you. So it's not information that we're going to easily give out. I mean, you can certainly find out if you want. I don't think it's all that helpful. You know that the longer you've been waiting on dialysis, the more likely you are to get a kidney. But it varies even between blood types, as I've tried to show you. So, yeah.
Well, PRA is not readily available at hemodialysis. In fact, they often don't tell you your blood type.
Yeah.
I'm just saying.
It's not information. We're not going to hide the information.
Right.
We didn't see a lot of purpose in disseminating it, because it is going to change, right? Your points are going to change every month. Having said that, if we have we'll have that data, and anybody who wants it can find it out.
Sure.
But it's where, again, what I'm trying to say is that just because you have high points doesn't mean you're going to get the next kidney, right? Because if you're sensitive, if you have points based on waiting time, yes, it could happen. But if you're sensitized, you still could be waiting a long time. It turns out that most of the sensitized people have been waiting the longest anyways. That's just the way it's gone.
Yes.
But
thank you, doctor.
We're not hiding it, for sure not.
No, I'm not suggesting that at all.
Sir. And not sensitized? So the question is, if you're sensitized, highly sensitized, are you any different than a non-sensitized patient? The answer is probably not, as long as we find a kidney to which you do not have antibodies against. So in the old days, the answer was yes, but in 2014, the answer is probably not much different. No. Not more drugs. If you think about sensitization, okay, what sensitization really means, let me go through here. What this PRA really means is the likelihood of finding a donor that you could match to, or the inverse likelihood. The higher the number, the closer you get to 100, the harder it is to find a donor for you. That's all that PRA really means today. Okay? The antibodies that make up PRA could be quite numerous, but this percentage from 0 to 100% is only really the ability to find a kidney to which you match, and that's why we're expanding the donor pool. So if my PRA is 50%, it means that 50% of the donors should be okay for me, and 50% I will have antibodies against. If my PRA is 75%, it means that 75% of the donors are not going to be good for me. I'm going to have antibodies against them, whereas 25% of the donors should be okay for me. So all it means is the higher your PRA, the harder it is to find a match for you. That's it. And we can't change that except by expanding the donor pool, which is what we're doing, from local to provincial to national. Yes?
Why is it that a recipient can receive any blood type from a living donor, but only their own blood type from a deceased person?
Yeah, so you're asking a good question. So how would you change this? I've already talked about the Bs. How would you change this? What would you do to the Os? The Os are fairly matched. So what would you do? Would you want to take all these O donors and give them to the Bs? Then you disadvantage the Os. So it's all about what you would like would be a system where the recipients matched the donors. And that's true for the Os. It's probably true for the ABs, but it's a small group. Where it's not true is here. And we can't give A kidneys to B recipients. We can give only the A, that's why we're doing it only with the A2s. But if you only cared about the Bs, you would start taking O kidneys to Bs, because you could do that. You could do that safely, but then you're beginning to disadvantage all these B recipients. Right now they're in balance. So yes, it can be done safely. It just can't be done ethically. Yeah.
Is there any time or instance where you actually give, for example, infectious, like let's say Hep B antigen positive to a recipient who has the same disease?
Yeah. So the question is, do we ever knowingly transmit viruses? So we never ever give someone with hepatitis B antigen to anybody. We will give someone who's had hepatitis B, who's cleared the virus, so they don't have antigen, they have what's called antibody, they don't have the virus, and we typically give those very safely. To be extra safe, we only give them to dialysis patients who've been immunized against hepatitis B or who haven't, and that's safe to do. So we never give hepatitis B antigen. Hepatitis C donors, we will only give to those people who have hepatitis C themselves, and that's on our list. There's only one person out of 330 who meets that criteria. Right now, today, and this may change, so stay tuned, we do not use HIV positive donors, although we have HIV positive recipients on the wait list. In South Africa, they use HIV positive donors for those people who are HIV positive. We may do that in Ontario. We are talking about it. We're seeing whether we can do that in a safe way, but we will never knowingly transmit a virus to someone who does not have that virus. So, and we don't use hepatitis B antigen for anybody, not for kidneys at least. Sir?
May I ask about the live donor system?
For sure.
If you're a B patient and you have someone who is willing to be a live donor, you still have to wait for a period of time until, I assume you have to wait for a period of time until a B donor becomes available. Does that affect the length of time you'd be on the list for a deceased donor?
Okay, so if I'm understanding your question, if you're waiting for a kidney and you have a live donor, whether you're B or AB or A or O, and you bring a donor to the table, let's say, because that's what you got to do, that donor will be, you're evaluated and you're a transplant recipient. So that's the first thing. Are you a transplant recipient? Let's say you are. Your donor will then be evaluated, and if your donor passes all the tests, and that's your only donor, that donor, if let's say your blood group is B, your donor is O or B, that donor can give you a kidney directly. All right? If your donor is A or AB, they can't give you a kidney directly, and then we can decide, do you go into our national paired exchange program, which is one option, and that's, and like yesterday, for example, Gallo and Maureen, his colleague, put 13 pairs of living donor recipients, donors and recipients into the system. We run this system 3 times a year. So if you have a donor whose blood group identical, you're B, you have a B donor, or compatible, an O can give to a B, then we can give it to you right away. If it's an A donor, let's say, then either you go in as a pair, or sometimes we'll do a desensitization. What if that donor doesn't work out for you? Well, you're on the wait list, okay? And we will put you on, and you'll go onto the wait list. We will put you on hold, though, if you get matched somehow, or if we're gonna match you, if you get matched in our national parity system, we'll put you on hold. But if you're waiting for a donor and it's not working out, you get onto the deceased wait list. So you can be on both wait lists, I think, if that's the question you asked. Okay? If you have a living donor, you certainly don't have to be on dialysis. And remember, it doesn't matter the blood type anymore. All you need is a healthy, warm body who loves you, and healthy. Healthy, I said. Healthy, warm body who loves you. Okay? Your girlfriend, just don't tell your wife. You know, whatever. Yeah. Sir.
Hi, sir. I have a question based on your experience and knowledge. Is it possible after the kidney failure is work back itself, like any cases happen?
I think you're asking is if you're on dialysis with kidney failure, can your old kidneys come back? Is that the question?
Yes.
Yeah. So sometimes if someone has what's called acute kidney injury, in other words, they had damage to their kidneys, and that injury can repair itself, people can come off dialysis. If you've got long-standing chronic kidney disease that has been progressing over months to years, and you end up needing dialysis, it's unlikely that you'll come off dialysis. I mean, maybe you might need less dialysis. That's a bit of a judgment with your physician. But most people who are on dialysis from a chronic, long-standing kidney disease can't come off. Sometimes people have acute kidney injury. They were sick. Their kidneys get damaged. They're on dialysis, weeks, months. They come off once in a while.
Thank you.
You're welcome. There was
Got
another question
here with the mic.
Yeah.
I heard a lot of questions about people being on hemodialysis. I'm on PD.
Yeah.
Is there any difference between that, I guess, as far as
getting a
organ
kidney?
donations? Yeah.
Yeah. So, no, the dialysis modality, in terms of all the things I've been talking about for the last couple hours, no difference whatsoever. There's no priority for hemo. There's no priority for PD. Whether you do home hemo, in-center hemo, home PD, doesn't matter. Doesn't matter. So there's no priority. Sir.
I'm a CKD patient as well. I've been on dialysis since 2008. Any chance to know what sequence, like our turn in the waiting list? Because like we might be going for vacation for summertime or something. We don't want to be called and we're outside or something. How does it work?
Sure.
Thank you.
So if you're on the waiting list and you think you've been waiting a long time, it's always a good idea to call Miriam and get some sense as to where you are. What we sometimes do, if you know you're going to be way out of the country, like somewhere off, you know, we may put you on hold just so we don't waste everybody's time for that period of time that you're away, you know, especially if you're near the top of the list, you know, and you might find that out. But again, there's so many variables there, but if you're not sure, it's always good to call to find out.
So Miriam would be the answer.
Yes, Miriam will happily answer. She loves speaking on the phone to people. Yes, sir.
If you're called in as a backup,
Yeah.
does that mean that you're kind of on top of the list? Or?
Yeah, there's a good chance that if you're called in as a backup, that means that you are pretty close to getting that kidney. Sometimes people will get called in 2, 3, and they're lucky on their 4th time. But usually, yes, that's a fair statement. Yes. Yeah, should be ready. So Miriam, the question is, how do we notify patients if we think they're near the top of the list?
Well, they can call me.
Yeah, they won't know. What we try and do is, because we have a very large waiting list, is sometimes what we try and do as a program is people who've been waiting a long time, we try and bring people in who we think are near the top 10 or 15% of the wait list and make sure they're okay, get their testing up to date, have them see anesthesia, and that is kind of a clue that we think you're near the top of the list. A long time for an A could be 4 years. A long time for a blood group B could be 7 or 8 years. An O could be 5 or 6 years.
Jeff, there's another question here. Okay, if St. Michael's has a system of notifying patients if they're already on top of the list. Now, few years back, we had an agreement with your dialysis centers that every year I'm going to send them names of who are those patients who needs updates for the year. So every December, I'm supposed to send that name, but except last December, because I'm waiting for the new allocation system, because whoever's on top of the list, that may change because of the point system. So I'm still waiting for that. Once I know who are the top 10% or 30% in our list, I'll be sending those names to your nurses, and your nurses will notify you that, you know, you are in the top 30% at St. Michael's, so we need the updates for you. So that's how that's the system that we have put in place.
Yeah, so try to see that we're trying to deal with what we think is the top 10, 15% of the wait list and make sure that everything is up to date. Because one of the problems is that we see you at one point and we rely on the dialysis centers to keep us up to date with you, but things do change. So we don't want you to be called in for a kidney and have any surprises. So we try and, as Miriam said, that's what I was trying to answer you, try and deal with the top 15% of the list. You can assume that if you're going to come in to see us about that, you're getting near the top. But even that could vary. The top doesn't mean next week. It could still be next year. Any last burning questions?
Any more question?
Thank you for your participation. Good luck to you all.
What's this?